Well, certainly, women really need evidence-based information, but for that you need individual data, not speculation. Overdiagnosis. You certainly heard the term overdiagnosis. It means this. Let me show you a case. When we started screening, I was working with a pathologist who was pretty much relaxed, and I took out all these calcifications, and then one case after the other, he told me that this was sclerosing granulose, this should not be taken out, and unfortunately I listened to him. And at that time it was a grade 1 in situ carcinoma. 18 months later, no change. 7 years later, if you really look at it very carefully, they start to fade away. But that took 7 years. And 9 years later, it changed. The grade 1 became grade 3. And this is too many dots, the neodotogenesis. These newcomers just wiped out the other one. They didn't at the histology. They are still there, but this dominated the picture. And there was a so-called 2 millimeter invasive carcinoma and a node positivity. And then very soon, she died from disseminated cancer. I just want to show you, practicing clinicians, that nice, cute, small babies may change for the worse. That's why we have prisons outside there. But it takes years. In this case, it took 10 or 15 years. Keep this in mind when somebody is going to tease you about overdiagnosis. Now, overdiagnosis means that if Morris is a good screener, he doesn't find 3 per 1,000, but he finds 6 per 1,000 or 7 per 1,000. So there is a pile of cancer here which comes from next year and next year. The lead time issue, right? So if you really want to talk about the extent of overdiagnosis, you have to adjust for lead time. And in the coming 2 years, breast cancer incidence would have gone up. So you have to also adjust for increasing incidence. Dear colleagues, here is the group of people who publish overdiagnosis. Look how much, but they did not adjust for lead time and increasing incidence. And here are the professionals who cannot publish because these journals decided to publish this. That's the story behind overdiagnosis. Like Tony Miller, I really confronted with him. He published a 25-year paper, but he reads out the 22% overdiagnosis in the middle. Not at 25 years, but 15 years. At 25 years, his paper shows a 3.7% overdiagnosis. Why does he publish the 15-year survival? Ask him. I ask him, and he cannot or is not honest to answer the question. So, conclusion concerning overdiagnosis. There are no credible data to support the conclusion that the majority of the cancers that you are detecting are overdiagnosed and they have never progressed to clinically palpable cancers. All-cause mortality, a very interesting issue. But you see, because we are compressing the breast, some people expect that all-cause mortality is going to go down significantly. Now, mammography is certainly a wonderful tool, but we cannot expect that after we have squeezed the breast, then the mortality from traffic accident or kidney cancer or brain tumor is going to go down. But if you ask the question, what is the all-cause mortality among breast cancer patients? Here is the answer. 19%. Significant decrease in all-cause mortality. That puts this one into bed. So all these can be very nicely reported and published, provided that you have a long enough follow-up of this chronic disease. Estimating short-term follow-up buys you a business class ticket and an open to New England Journal of Medicine. And then, of course, you are talking about harms. Dear colleagues, early detection and treatment in early phase is decreasing breast cancer death. The take-home message is that moving back in time in the natural history of disease, which is not a systemic disease from the outset, but rather progressive disease, can prevent. I didn't say it does, because in Toronto it didn't, but in the rest of the country it did. It prevents death from the disease. So again, the conclusion is that it's not what we are doing with the breast cancer patient makes a difference, but when do you apply this, early or late in the natural history of the disease. So finally, I think that there is a lot of light at the end of the tunnel. We should really continue training our technologists, our radiologists. It's an extremely hard work. And then we should have these tumor boards. And just look at our tumor board. It's like an IMAX studio. It's not a little handkerchief in the wall, which nobody looks at, but there are the 4 screens. Here is the truth. Large section histology. And it's low resolution reflection called the mammogram, ultrasound, MR. And now comes the ultimate truth, the pathologist and the surgeons, radiologists sitting all together. Finishing up, Blake Cady is absolutely right when he wrote this 13 years ago, that successful early detection can be considered a major public health movement. Opponents of mammography used to discredit the most important control mechanism for breast cancer death ever invented. Thank you.